Here today. I think I'm the only ambassador from the country of baguette and croissant. But so it's my pleasure to present you the view from France about the past, present, and future of BTC. So first, a word about our organization for clinical trials in France, because it might seem confusing from abroad. We have 3 cooperative groups that can be endorsed to be academic sponsors for clinical trials. So the first one is the GERCOR, that has been historically funded by oncologists. We also have the FFCD, which has been funded by gastroenterologists. And lastly, we have UCGI, which is for clinicians working in cancer research centers. And these 3 organizations work together within the PRODIGE intergroup. And so when we need to build large clinical trials involving all the centers in France, we work within this intergroup, and we have specific subgroup for each cancer type, and I'm one of the leaders for the biliary tract subgroup. We have national guidelines, so at the European level, we have the ESMO guidelines for oncology, the EASL guidelines for hepatology, and in France, we have national guidelines developed from these European guidelines. So for oncology, it's the TNCD, which is written with an input from all the scientific associations involved in the treatment of BTC. And we have also recently an initiative from hepatologists to propose specific guidelines, so from the AFF. And so the TNCD guidelines will be updated this year, and the AFF guidelines will be published this year. It's important to have these updates because of a recent evolution in the management of BTC patients. So in France, we don't have a chance to have patient advocates for BTC, and until recently, we didn't have any specific scientific association for BTC. So we created in 2018 the ACABI Association, which is to bring together clinicians and researchers working in the field of biliary tract cancer to conduct multi-center research. And so we already have a clinical registry where nearly 1,000 BTC patients collected since 2003. And we also have translational projects that are ongoing. We will have our first scientific conference in Paris in September 2022, because since the creation of the association, we also had the COVID problem, so it was not possible to meet in person. So one word about the incidence of BTC in France. So it's necessary to mention that in France, we don't have a national epidemiological registry for BTC. So we have either regional registry from which we do extrapolation to approach the total number of cases, and we have the PMSI registry, which is the national healthcare system, but it's not built for epidemiological purpose. It has been developed for financial issues in order to reimburse the center for the care they give to the patient. So based on these regional registries, we estimate that we have between 3,000 and 4,000 new cases of cholangiocarcinoma each year, with approximately 1,000 in intrahepatic cholangiocarcinoma. But from the PMSI database, we have the impression that there is an underestimation of the number of intrahepatic cholangios in the regional registries. And we probably have the same trend as in other Western countries, with an increase in the incidence of intrahepatic cholangio in France, while extrahepatic cholangios are quite stable. Regarding our healthcare organization, it's also important to mention, because we talked about expert centers, but in France, the management of these patients is truly decentralized. In the PMSI study, we realized that the majority of these patients are treated in centers in which they see only 1 or 2 cholangio patients each year. So it's something very disturbing. The majority of patients are treated in general hospital, but maybe there is a lack of awareness about this disease in this small center. And a striking finding we made is that 2/3 of the patients with intrahepatic cholangios are treated with best supportive care only. So maybe because there is a part of late diagnosis, but also possibly because of a lack of awareness about this disease in this small center. So there is truly something to do in terms of learning of the professional as well. And also an important point is that we discovered that 1 patient out of 4 died at the first hospital stay. So it's also something to mention about the severity of this disease. So about chemotherapy and our practice in France, there is two things you need to know about French to understand my next slide. Is that first, we are rebels. It's difficult for us to follow the rules. We are always keen to go on strike. And another point is that we love oxaliplatin. We are the land of Emery de Grammont and the Optimox regimen. And so oxaliplatin is something we truly like. So even if since 2010 we had the ABCO2 trial showing that GEM-CIS is the best regimen for cholangio patients, in France, we have been using GEMOX, so gemcitabine plus oxaliplatin, in the vast majority of our centers. And so in our national cohort of second-line treatment, we observed that more than 90% of patients received GEMOX as first-line therapy, because our usual sequence was GEMOX followed by FOLFIRI. And as we like Optimox strategy, we did also a lot of gemcitabine maintenance therapy, even if we have no scientific data to support this strategy, but we are French, so we do what we like. But following the results of the FOLFOX second-line treatment, we accepted to drop oxaliplatin in the first-line setting because we were going to use it in the second-line setting. And so in a recent national practice survey, we showed that now the majority of clinicians in France do use cisgem as first-line regimen and FOLFOX as second-line regimen. But still, it's difficult for us to follow the rules, and so we don't prescribe it as we should. We hospitalize our patient to do GEM-CIS while it's not necessary. And a lot of clinicians do perform gemcitabine maintenance, even if we don't have prospective evidence for this practice. And so we are now waiting for our regulatory authorities' position regarding the access to durvalumab in order to have our practice changing following the results of the TOPAZ study. There is something we love more than oxaliplatin, it's the FOLFIRINOX regimen. We do it in all the indication in GI cancers. And so we contributed to the field of first-line chemotherapy with the AMMF trial, in which we tried to show that FOLFIRINOX was better than GEM-CIS, but we failed. And so GEM-CIS remained the main regimen in the first-line setting. In the second-line setting, I showed you that most of us do FOLFOX, but we are still wondering whether a 5-FU monotherapy could not have a similar activity in our patient. And in our large second-line database, we had more than 400 patients, and we analyzed the effect of 5-FU monotherapy versus doublet with platinum or immunotecon, and we showed that there was no survival difference, even when we took into consideration the performance status of patients. So this is why in France, in some centers, when we have patients who are not fit for FOLFOX, we very easily use 5-FU monotherapy or capecitabine as an alternative. And we are waiting for the results of an ALYRIC trial to have a true comparison between 5-FU monotherapy or doublet. Regarding targeted therapies, the road to success for targeted therapies has been long, and at the beginning, we had a succession of negative trials, when we were giving these targeted therapies to unselected patient population. And we contributed to this series of trials with the BINGO trial, for example, using cetuximab in combination with a GEMOX regimen, which was unfortunately negative. We also participated in a small single-arm phase 2 trial in the second-line setting using anti-angiogenic, specifically in patients with intrahepatic cholangiomas. We had a signal in favor of anti-angiogenics in this subset of cholangio patients, but it was not further confirmed by specific randomized phase 3 trials. Then we had the success that came from personalized targeted therapies, and molecular screening was something implemented very early in cancer research centers. And so centers from France, such as the Gustave Roussy Institute, published their experience in terms of molecular screening of patients and showed among the first that they observed a signal for specific targeting of ADH1 mutation or FGFR fusion before the large clinical trials that you all know now that allowed these drugs to be recognized as true therapies for our patients. We had a meeting organized in France between our national regulatory authorities and the ACABI Association in order to get a consensus about what should be done in all our patients in terms of molecular screening. And so we get a consensus to say that we should look for mutations in INDH1, KRAS, and BRAF, for fusion in FGFR2 and NTRK, and also for HER2 status and MSI, to be proposed to all patients with advanced biliary tract cancer when they are PS0 or 1. And it has to be done early in the patient trajectory in order to get the result for the second-line therapy of these patients. This consensus will be included in our national guidelines, and we are pushing it against our regulatory authorities to propose targeted therapies in the second-line setting, while the ANSM and the HAS want us to prescribe this drug more in the third-line setting, but we think we should propose it to our patients in the second-line setting rather than for folks when they have an actionable alteration. So the future, it has been presented earlier, is the Saphir ABC10 trial that will, we hope, allow the validation of personalized medicine in a prospective trial. And we also explored in France immune therapy. So in the second-line setting, with the support of AstraZeneca, we ran the Eminobil trial, which is now over. It's a trial in which patients with biliary tract cancer in the second-line setting received a combination of durvalumab plus tremelimumab. We had two cohorts, a first cohort with the usual regimen of tremelimumab, 4 cycles at 75 milligrams, and then we had an amendment to give patients only 1 dose of 300 milligrams of tremelimumab. The first cohort is now mature, and it will be presented at the next ASCO conference, and we will soon present as well the results of the second cohort. And in this trial, we had a large panel of ancillary studies performed with a mandatory rebiopsy of all patients at inclusion in order to expand the knowledge about predictive biomarkers of response to immune therapy in these patients. And we are now exploring for the future immunotherapy in the adjuvant setting, and we hope we will start by the end of the year the Immunobil-ADJ trial, in which patients with resected biliary tract cancer will receive either capecitabine or capecitabine plus durvalumab. In the adjuvant setting, we also tried to get our GEMOX regimen validated, but as you know, the PRODIGE 12 trial led by Julien Hedlin was negative. GEMOX and other gemcitabine-based regimen are not more active than nothing, than surveillance. It has been confirmed in a meta-analysis, and in our practice survey, we also show that clinicians in France have adopted this practice, and they use capecitabine in the adjuvant setting in a vast majority of patients. And we are waiting for the results of the ACTICA-1 phase 3 trial. Finally, regarding intra-arterial therapies, so Julien Hedlin in France has been very active in this field. He was the leader of the MISFEC trial. It was a single-arm phase 2 trial in patients with locally advanced intrahepatic cholangio, and he showed that using SIRT in combination with chemo allowed patient dose staging and then surgery, even with large tumors. He also recently published this meta-analysis in collaboration with our English colleague on the different strategies for local regional therapies. In France, SIRT is reimbursed when we use it in combination with chemotherapy, but the difficulty we have is the access to this technique because it's still limited to some specialized center, and so not all patients can get access to SIRT. We still develop clinical trial to validate this technique in the neoadjuvant setting now, and Julien Hedlin has launched recently the Sirocco trial, which is for patients with upfront resectable intrahepatic cholangio, and it will compare upfront surgery to a neoadjuvant approach with capecitabine combined with SIRT. And I will go straight to my conclusion slide to say that regarding epidemiology in France, we have a probable underestimation of intrahepatic cholangiocarcinoma cases from registries. For the diagnosis, it's often made at an advanced stage, and supportive care play a central role and is the only treatment in a high proportion of our patients. The chemotherapy sequence with GEM-CIS followed by FOLFOX has been well integrated, but we have deviations regarding the modalities of administration in our French clinician. Alteration in IDH1 and FGFR2 are acknowledged as clinically relevant and should be looked for in all patients. But the question now we have is how it will be implemented in the routine practice. So with the ACABI Association, we are currently organizing regional meeting because we have to discuss it region by region in France to implement this routine access to molecular screening for our patients. Regarding immunotherapy, we are waiting for our regulatory evaluation to get access to this new class of drug for our patients. And for local regional approaches, the access to CERT is still limited to a small number of expert centers. I thank you for your attention.